College of Surgeons as an ENT surgeon. He also has an MEd from University of Pretoria in otorhinolaryngology, that word. He's a dedicated ENT surgeon with expertise in otorhinolaryngology, encompassing ear, nose, throat, and also head and neck surgery. And he excels in sinus surgeries, addressing conditions like chronic sinusitis and nasal tumors, and is skilled in handling acute surgical emergencies. Additionally, he provides comprehensive pediatric care for sleep disorders, tonsillitis problems or tonsil problems, ear discharges, and congenital nasal and laryngeal abnormalities. He also performs excisions for salivary gland tumors and various head and neck procedures. His commitment to both elective and emergency cases demonstrates his dedication to improving patients' health. He operates from Tepatemba Hospital in Dobsonville, and also does some work at the Dr. S.K. Matsiki Memorial Hospital, and also quite busy at the day hospital that we have at the GMPG in the CBD. So we're excited to have you with us, Dr. Lumata, and you have quite a sizable number of people waiting to hear from you this evening. Thank you very much.
Thank you very much, Dr. Pila. And thank you so much for this opportunity as well to the entire team. And a special thank you as well to everyone who has joined in. I do hope that after this presentation, we all would have learned and our approach to the theme for the night would improve. Can you see my slides? Can you see them moving before I can start?
Yeah, they're moving.
Yes, Doc.
Thank you so much. On that note, I am going to shift and minimize this. So I'm hiding the thumbnail over there. Good. Everything is still clear, no?
Sure.
Yes, Doc, everything is fine.
Great. Good evening, colleagues, once more. The topic we are doing tonight is sinusitis. There's going to be more focus on acute bacterial sinusitis and the complications that arise from thereof. Of note, we should all know that rhinosinusitis is a common clinical problem in both a pediatric and adult population. And in cases where there is bacterial disease, amoxicillin is the first line of treatment. We'll go into further detail on regards to management. By definition, rhinosinusitis involves inflammation or infection of the sinus mucosa, and which is continuous within the course of the nasopharynx. And of note is the term rhinosinusitis. It comprises a heterogeneous group of related conditions. So we can categorize it based on its anatomical location or on the duration of symptoms, whether it's acute, subacute, recurrent, or chronic, and whether it's infectious or non-infectious. Details are to follow. Of note is that most cases of sinusitis are viral. They're caused by viral pathogens and therefore do not require routine use of antibiotics. We'll get to discuss that a bit later. And then the complications of rhinosinusitis, particularly bacterial acute rhinosinusitis, are uncommon and they can be very difficult to recognize in the early stages. But of note is that they are life-threatening, and by the end of this presentation, I do hope that we would have an idea or on when to refer. And yeah, starting on anatomy, this is a talk on sinusitis, so the pathologies in the sinuses. Now, we've got four groups of sinuses, and by definition, a sinus is an air-filled cavity, and we've got four groups, as I've said. We've got the frontal sinus over here. I hope you can see my mouse moving. We've got an ethmoid sinus over here. We've got the maxillary sinus, and we've got the sphenoid sinus. Okay. Now, these sinuses, that is the frontal sinus, ethmoid sinus, maxillary, you can even see on this picture, frontal, ethmoid, maxillary. We can see that they are closely related to the eye. So we can say that the sinuses are located superiorly, medially, inferiorly and posteriorly to the orbit. Now, the first sinus to pneumatize is the maxillary sinus, followed by the ethmoid sinus. The frontal sinus and the sphenoid sinus pneumatize late by the age of 12. So when we're seeing pediatric cases, if a child is 4 years, generally we know that the infected sinuses would be the ethmoids and the maxillary. Rarely would you get a sphenoid sinusitis or a frontal sinusitis in a 2-year-old because they're still in a process of pneumatization. Again, also our anatomy is important. Look at the orbit and how it closely relates to the ethmoid cavity or the ethmoid sinus. We've got a very thin wall that separates the ethmoid sinus from the orbit. We call it the lamina papyracea. And this is one of the reasons why orbital complications are common. Sphenoid sinus, yes, it's a very intricate sinus because in its lateral extent, so this is an axial view of paranasal sinuses. This at the back is our sphenoid sinus. From sagittal, this is our sphenoid, this is the sphenoid, this is the sphenoid sinus. Then axial, this is a sphenoid sinus. Now, what you need to note is laterally on the sphenoid sinus, we've got a cavernous sinus. And within this cavernous sinus, we've got cranial nerve number 3, cranial nerve number 4, and cranial nerve number 6, which is the abducent nerve. And we've got a branch of V1 and V2, and also the internal carotid artery. When infection spreads from the sphenoid sinus into the cavernous sinus, the first culprit of nerve to be affected is the abducent nerve. Now, what's the drainage pattern of the sinuses and what's the pathophysiology? Frontal sinus above the orbit, ethmoid sinus medial to the orbit, maxillary sinus inferior to the orbit. They all drain through a common channel. This is the channel that we call the osteomeatal complex. This drains the sinus secretions into the middle meatus. Any form of obstruction in this osteomeatal unit will cause or will affect the drainage pattern of the respective sinuses. That would cause ciliary dysfunction. It will cause stasis of secretions that provides the needs for bacterial growth. And that's how we ultimately get to get a bacterial sinusitis. So by definition, a sinusitis is the inflammation or infection of the sinus mucosa. But because the mucosa of the sinus is contiguous with the nasal passages, these two are often concurrently affected, and hence why we call a condition rhinosinusitis. Now, what are the clinical features that one should look for? There's various clinical symptoms that patients may present with, and these include nasal congestion or nasal blockage, a nasal discharge, could be anterior or posterior, post-nasal drip, facial pain or facial pressure. Usually patient will say, "Doc, here my eyes, it's like they're going to pop out." If there's an altered sense of smell, you ask the patient, "How's your sense of smell? Is it good or is it bad?" That would also be an indication of the presence of sinonasal disease. Then other symptoms would be fever, headache, dental pain, and halitosis. But unfortunately, these symptoms, they are not specific for either bacteria or a viral infection. So we do know that the symptoms, they tend to overlap considerably. And this is why now this presentation is important, because we need to be able to recognize at what point is the infection bacterial and at what point do we give antibiotics, at what point to refer to an acute hospital for further treatment. Now, just for simplicity, so that we also get to familiarize ourselves and so that it also sticks, we must have this mnemonic in our head: PODS. PODS, P being pain, facial pain or pressure, O, nasal obstruction, nasal discharge, and a smell disorder. From a primary care setting, 2 or more of these are diagnostic of a rhinosinusitis. Or if you get one of these, plus other minor symptoms like dental pain, headache, fever, postnasal drip, then it's diagnostic. So let's all remember POTS: facial pain or pressure, obstruction, discharge, smell disorder. Now, in advanced centers where we've got endoscope and CT scans, then there's additional criteria into the diagnosis of sinusitis, and that is with endoscopic findings, we'll have to look for the inflammation of the sinus mucosa, edema or micropurulence in the middle meatus. CT scan will show some mucosal thickening or air fluid level, of which also that will help you to grade the severity, but we are going into the detail. Now, the focus of this presentation again is on acute bacterial rhinosinusitis. So what defines as acute? Acute would be symptom duration. Again, these symptoms: POTS, facial pain, obstruction, discharge, smell disorder, 2 or more. If they persist for less than 4 weeks, that is an acute sinusitis. If they go for more than 3 months, over 12 weeks, that is a chronic rhinosinusitis. Acute, less than 4 weeks. This is very important. Now, at what point would we say the infection is bacterial? If 3 or more of the following are present: there's fever above 38 degrees. If there's double sickening, so a double sickening is patient would improve. So initially, patient would have sinonasal disease symptoms, rhinosinusitis, and then there'll be a period of improvement. They feel like, okay, no, they're getting better. And then there's this acute onset where they're deteriorating or worsening. That is double sickening. So if a patient initially, they're improving, and then there's this deterioration, that is double sickening. It should raise an alarm of bacterial disease. If there's unilateral disease or severe pain, if the mucus is discolored, it's macropurulent, or if there's raised inflammatory markers, that is our ESR or CRP. 3 or more of these are diagnostic of acute bacterial rhinosinusitis: fever, double sickening, severe pain with discolored mucus, and raised inflammatory markers. So we can also diagnose bacterial disease without these inflammatory markers based on fever, double sickening, severe pain, and discolored mucus. Now, how does a patient develop a bacterial sinusitis? As I've explained, this osteomeatal unit or channel is important. Once it's blocked by any of these predisposing risk factors, that creates or it affects the drainage pattern of the respective sinuses. Once that has been affected, now you get stasis of mucus. Once there's stasis of mucus, bacteria proliferate, and that ultimately leads to inflammation of the mucosa and the sequelae. So what predisposes to bacterial sinusitis? There's several risk factors that have been identified. First one is the dental infections, but dental infections would be more for maxillary sinus because there's a thin alveolar plate that separates the maxillary sinus from the molar tooth, or molar teeth rather. So if there's infection in the dental cavity, it can spread into the maxillary sinus. Number 2, any form of mechanical obstruction in this osteomediatal complex does predispose to onset or development of sinusitis. Foreign bodies, which you commonly see in children. Children would usually present with this discolored mucus that is foul-smelling. A discolored mucus, foul-smelling in the pediatric population is a foreign body until proven otherwise. And when that now, when those secretions start to be foul-smelling, that also becomes an indication of a development of discolored disease. Of bacterial disease. Another thing that predisposes to development of sinusitis is mucosal edema. Antecedent upper respiratory tract infection will usually cause edema of the sinus mucosa. It obstructs the unit, and then the pathophysiology, as I've explained. Immunodeficiencies, patients who are HIV, IgE deficiencies, impaired ciliary motility. Smoking as well does increase the risk of sinusitis because smoking, number 1, it impairs the ciliary function. Number 2, it alters the normal bacterial flora of the sinonasal mucosa. So it therefore increases colonization of more bacteria, which are potentially which could potentially cause infection. And lastly, heterogenic causes would include insertion of NG tube because obviously we are blocking the sinus ostia. What investigations do we do? Plain radiographs, we've got more sensitive investigations now. So X-rays, we are no longer recommended. CT scans is most definitely. MRI only in cases of intracranial complications or of a soft tissue complication because MRI provides better soft tissue delineation. So with a CT scan, when do you scan this patient? Patient look at recurrent acute bacterial sinusitis. Recurrent meaning they're having more than 4 episodes in a year. There is an indication to do a CT scan. Patient with chronic sinusitis, patient whom their symptoms would persist after completing medical therapy or in cases of a complicated sinusitis, that is in the setting of the hospital, that's when we actually do an MRI. And if we see mucosal thickening that is more than 5 millimeters, that is suggestive of infection. This, as we can see, is an axial CT scan of the paranasal sinuses, and we can see an air fluid level on the left maxillary sinus. Also, the sphenoid sinus here is affected. Further investigations, generally we recommend a CT scan. We don't recommend blood cultures because they correlate poorly with the cultures that we aspirate from sinus mucus. Ultrasonography, they do speak about it in literature, but we rarely, if never, ever do it. Now, what are the commonest causes of bacterial sinusitis? 3, it's Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. However, there is cases where you get polymicrobial pathogens. In cases of a complication, the identified bacteria are the anaerobes in 38% of the cases, Streptococcus viridans, and Staphylococcus species. And in cases where the disease is severe to a point where there's abscess formation, Streptococcus miliaris has been the culprit. How do you manage acute bacterial sinusitis? This now becomes, that's where a lot of controversy comes because there's a lot of, or a few rather randomized control studies that have been done. In terms of prescribing antibiotic in acute bacterial sinusitis, the benefit is in preventing the worsening of symptoms rather than to provide symptom resolution. Number 2, some studies have shown that the antibiotics shorten the symptom duration by about 2 to 3 days. Unfortunately, the rate of complications and recurrences do not differ. Whether you prescribe or not, antibiotics generally do not prevent a complication from occurring. However, we do recommend giving antibiotics in certain cases of acute bacterial sinusitis, and this should be in patients who are showing a severe disease, that is patients who are having a high fever, patients who don't show improvement after an initial conservative therapy, and patients who show double sickening. Where double sickening, they initially get better, and then there's that acute onset where they deteriorate. So patients who are having severe symptoms, those are the patients that we can consider antibiotics for, but not routinely for any rhinosinusitis, because you know that commonly it's the viral process, but even with bacterial, role of antibiotics are not greatly beneficial, and they don't prevent complications. So ideally, generally, you want to start conservatively with intranasal steroids, saline washes, decongestants, and then if there isn't improvement after about 5 to 10 days, only then you can add an antibiotic. And our first line is amoxicillin with clavulanic acid. And second line, in addition to augmentin, you increase the dose, and then you can add clindamycin, or you can add fluoroquinolones and doxycycline. Pediatric population, again, you give augmentin, amoxicillin, and clavulanic acid. Give at a dose of 30 milligrams per kg per dose. And then second line, if there's no improvement, then you can give clindamycin. Now, how to manage bacterial rhinosinusitis? As I've said, initially we become more conservative and we give intranasal steroids because of their anti-inflammatory properties, number one. Number two, they've got a local bioavailability, meaning that there isn't systemic absorption of the intranasal steroids. And the advantage of using intranasal steroids is you prevent the complications of using systemic steroids. Now, we can use Becklate, we can use Flomase, any of the intranasal steroids really we can use because there isn't really, in terms of improvement of symptoms and in terms of benefit, they all almost effective, especially in the acute setting, especially Becklate, because Becklate has got it's got 1% higher a rate of local bioavailability. So in some cases, actually, monotherapy with intranasal steroids can be effective. However, we like to give adjunctive treatment because we want it better for our patient. So what we add as an adjunct is Salix wash, irrigating with the normal saline. This one, it helps in removing mucus and environmental irritants. And it also helps in restoring a normal mucociliary function because we do need the sinuses to drain, they need to ventilate. So a Salix wash is highly recommended in conjunction with the intranasal steroids. Furthermore, yes, we can give decongestants. We prefer topical ones, the Eledi nasal spray, for example, and these should be limited to 72 hours. Analgesia, yes, definitely for headache, we can give paracetamol or NSAIDs. They are safe and effective. Opioids generally are not recommended because of their side effects. So just to summarize the slide, focusing here on primary care, if patient shows or depicts signs of acute bacterial disease, which will be characterized by a fever of more than 35, double sickening, unilateral disease, severe pain, discolored mucus, or raised inflammatory markers, you start conservatively with the intranasal corticosteroids, give decongestants for 72 hours, they flush or spray their nose, and then you monitor that patient closely. It's important to monitor the patient weekly at least to see if there's deterioration or if there's worsening or if there's improvement. Because now, if there is deterioration, then we can actually escalate to antibiotics. Now, the next few slides are going to be focusing on complications and when to recognize a complication, when to refer. Once the patient develops orbital symptoms, once this periorbital edema displays globe, patient complains of double vision, diplopia, if the motility of the eyes is affected, if there's a reduced visual acuity, severe headache, frontal swelling, the signs of sepsis, signs of meningitis, meningism, or if there's neurological signs, you refer these patients immediately. Complications are rare, but they can be very severe and life-threatening. And we generally divide them into intracranial complications, extracranial, and osseous complications. Few pictures for us to see. Again, child presenting with a history of a flu, then later develops unilateral orbital swelling, immediate referral, because this means that child has got ethmoid sinusitis, sphenoid sinusitis, with a collection in the subperiosteal space of the lamina papyracea. This child has got a subperiosteal abscess. This needs an immediate referral to ENT, then we manage further. Other complications are bony complications, where now you get this osteomyelitis in the frontal table of the frontal sinus. Sorry, in the anterior table rather. This is the frontal sinus. This is the anterior table. This is a posterior table. Once there's infection into this frontal sinus, it can cause an osteomyelitis into the anterior table, which subsequently develops into a collection, an abscess. This we call a Potts-Puffy tumor. And at this stage, when patient has developed complications, we start talking about IVI antibiotics. We start talking about surgical drainage. Bilateral orbital swelling very, very much raises a high suspicion of a cavernous sinus thrombosis. So when there's bilateral orbital swelling, chemosis, ophthalmoplegia, reduced motility of the eyeball, With this, you need to urgently do a CT scan and you look for a filling defect because this patient has got a cavernous sinus thrombosis. And at this point, we intervene surgically, give IV antibiotics. So extracranial complications of sinusitis, as you've seen in the few pictures, include orbital cellulitis, a subperiosteal abscess, an orbital abscess, postpartum tumor, and mucosal is latent. And of note is these complications are more common in the pediatric population, and they are more common than the intracranial complications. Intracranial complications, they do occur in a few patients, and epidural abscess is the most common, followed by subdural empyema. Meningitis and cavernous sinus thrombosis have been reported as well. And the pathophysiology of intracranial SPED is that you get this septic emboli transmitted through the diploid veins, which are in the skull base, and they penetrate the dura. Furthermore, if there's osteomyelitis, direct extension through osteomyelitis or through bony defect or skull ostia causes intracranial seeding. And again, these complications tend to occur more commonly in children than in adults. This is an example. It's an axial scan. It's an MRI. And this is a patient who had actually developed an epidural abscess. And at this stage, we involve our neurosurgery colleagues, and there's this multidisciplinary team that's involved to treat this condition. Now, out of interest, when it comes to complication, is there room for conservative treatment? Yes, most definitely. And those who are interested can actually check the Schindler classification. In certain cases of complications, for example, a patient who gets an orbital cellulitis or preseptal cellulitis, you can manage conservatively with IV antibiotics and our intranasal treatment. Some cases of a small subperiosteal abscess, we can also manage it conservatively. However, most of the patients at the point where they've developed an abscess, they need surgical intervention. Now, we can then discuss which surgery is better. We've got external approaches. We do external frontal ethmoidectomies, and we've got endoscopic approaches where we do a functional endoscopic sinus surgery. With the external approaches, we generally make an incision medial to the eye to gain access into the ethmoid sinuses if they're affected. This we call an external frontal ethmoidectomy. In cases where the frontal sinus is involved, we would extend this large incision below the brow, elevate the tissues, and drill the anterior table of the frontal sinus to drain the pus. Endoscopic work, it offers better visualization, and generally it's got a better outcome. And this is our setting. This is a patient that we did at Dr. S.K. Matseke, but it was not a sinus case. Just to show you the setting, everything is done endoscopically. We've got a screen. We sometimes get a neuronavigation. Yeah. So this one was done at Tipo-10 by pardon the head extension. But the advantage really of doing endoscopic work is that access is better. Access is better. It does not leave patient with external scars. And as you can see, camera in, if we zoom this closely, we can see the pus coming from the middle meatus. We suction, we open the sinuses nicely, we flush, and then there'll be better delivery of the intranasal corticosteroids in getting into the sinonasal mucosa and reducing the inflammation. I hope this presentation was helpful. What a take-home message. We should have a high index of suspicion of bacterial disease if a patient worsens or if there's worsening of symptoms or acute deterioration once the patient has had a flu. And then also a take-home message is that we should follow our patients closely, particularly those who present with acute sinusitis, and we should consider giving antibiotics to those who start showing signs of bacterial disease. And if there's any eye symptoms that develop in a form of swelling, motility being involved.
Doc, are you still there?
Oh. Excuse me? Hello?
Yeah.
Hello?
Yeah, we almost lost you there. I thought you were doing a repeat of last week's. presentation when you lost the presenter several times. But we can hear you.
No. No, okay, good.
Your screen froze a little bit there.
Oh, sorry. Did you see this one?
Yeah.
Hi, Dr. Vila. Hi, it's Kamu. I think maybe your bandwidth is low because I didn't lose Doc. His
okay.
connection was fine until now. Yeah.
Okay. He didn't say anything to me. It doesn't say
Yeah.
that my bandwidth is low. Okay. Thank you very much, Dr. Lumata. Thank you for quite an incisive presentation and also a pictorial presentation, and also seeing the work that you do both at all three hospitals, Temba, Dr. SK, and the GMPJ, and an overview of what chronic sinusitis looks like, and treatment, conservative management, and up to your surgical intervention. We'll take some questions. We're excited to have this Ronald Spit, who's joining us from Ireland, and I know that Prof. Makunyan is also joining us from Uganda this evening. We have a few questions for you, Dr. Lumata. If we start with the first one, is how do you prevent flu from complicating into acute sinus or sinusitis?
Thank
Maybe
you for
if you
that question.
switch off your stop your presentation, or you want to still use it?
Stop share.
Okay, stop share. Yeah, thank you. Okay, the first question is how do you prevent flu from complicating into acute sinusitis?
So that's actually a very good question, Dr. Bila, and it also brings back the argument of the antibiotics. Unfortunately, we can't. We need to give. We need to treat the flu early with intranasal steroids. We need to give a patient saline irrigation so that we can clear the environmental irritants and improve mucociliary dysfunction. But at that point, we don't give any antibiotics because antibiotics have not been proven to prevent a development of bacterial sinusitis or even the complications thereof. And what we do is we generally recommend that we don't, as doctors, we should stop routinely prescribing antibiotics for flu because then that increases our resistance, the spectrum of resistance, and yeah, just makes patients prone to more severe disease with less or limited drugs to use. So unfortunately, just intranasal steroids, saline irrigation, use topical decongestants. You can give analgesia, Panadol, NSAIDs for pain, and yeah, we can't prevent it from happening. But yeah, we need to treat the acute infection.
Okay, Dr. Motlanthe is a bit naughty. Referring to Dr. Mkhize and Postin Zuma. He says, how do you deal with post-nasal drip? I see people are put on proton pump inhibitors, etc. Could this be due to sinusitis, reflux, or nasal polyps? As I mentioned, that says Dr. Mkhize and President Zuma to clear their throats now and then.
Okay, so with a post-nasal drip, there's no role for PPI, and that we need to be clear, all right? And we also need to establish what is the role of a post-nasal drip. You must ask if a patient has got any allergies, and it's also good to do an IgE at your talk to screen for inhalant allergies, all right? And generally, you would want to treat this with an intranasal corticosteroid. You can use a Flomist, you can use a Genemy spray, and the method of administration becomes important because some patients have these refractory symptoms because the administration of the treatment is not correct. If you want medication to get into your sinonasal mucosa, you don't just face straight like this because it's going to drip back. It must face just to the side, into the corner of the eye, then it's able to reach into your sinus mucosa. So question on how you treat postnasal drip, after further investigations and excluding allergies, you give an intranasal corticosteroid. If there is an element of allergy in a sense of sneezing, itching, then you add an antihistamine, and generally we like to use Taxat because it does not cause drowsiness. And then at the issue of a PPI, unless there's a chronic laryngitis, but it's got no role in rhinitis.
Okay. And well, Dr. Novondo, one of the chats, he says, no, nothing from orthopedics. You know, your colleague from Temp, he's here also joining the webinar.
Excellent, Delani.
And yeah. And then Dawood says, tell us about supraorbital extension spread of infection. I think you did touch on it, but I think you're just too, yeah.
What's the question?
Supraorbital extension spread of infection. If you can comment a little bit more about that.
Can I just share my presentation? Then it's gonna be more clear.
Okay, sure, that's fine. Yeah.
So, is it clear?
Yeah, we can see it. Yeah.
So remember when I described the relation of the sinuses to the orbit? Medially, we've got this ethmoid sinus. The division between this ethmoid sinus, the division between, oh man, what did I do now? Sorry.
We can see. I don't know what. You want to go to presentation?
I want to go to that picture and it makes it easier. Good. Now, if you can check the ethmoid sinuses, for example, and orbital complications are common and part is because of this. The ethmoid sinus, maxillary sinus. Look at how they're closely related to the orbit. There's just a thin dividing line, which we call, dividing bone, excuse me, which you call a lamina papyracea. So if this bone is infected and osteomyelitis occur, infection can spread. If this bone is dehisced, infection can easily spread into the eye, all right? So even with supraorbital, if you can look at the frontal sinus, I don't have a CT scan that shows nicely the frontal sinus, but if you can also look at the frontal sinus, all right, a spread into adjacent structures not only by direct extension, but also septic emboli, right? Blood, what we call it, hematogenous. There is also hematogenous spread into the orbit and also into the intracranium. I'm not sure if that answers the question.
Yeah, I think it does, yeah. So then the next question then says, Dr. Soteti, well, if you spoke about the first line of treatment. Now you want to know, is it amoxil or amoxiclav? because you wrote amoxil plus or minus.
It's amoxicillin plus clavulanic acid because it's got a better synergistic cover. We have a lot of resistance to amoxicillin now. So the better treatment is a broad spectrum antibiotic, which is augmented. It works very well. It works very, very well. Cephalosporins, yes, you can. We can always add cephalosporins, especially to cover the anaerobic, to cover gram negatives. Please pardon me. To cover more gram negatives. But unfortunately, there has also been resistance into the second generation and the fourth generation cephalosporins. However, yes, that can be added as an addition, as a second line, in addition to augmentin. So you don't want to exclusively use a cephalosporin, but you want to use augmentin and add a cephalosporin for second line. Yes, if the patient is allergic to penicillin, then it is safe to use a cephalosporin.
Okay. Okay, thank you. So augmentin is the choice.
Augmentin is a choice, yeah. And also adequate dosing, especially in the pediatric population, that is vital. Adequate dosing. In kids, it's 30 milligrams per kg per dose.
Yeah.
And you give it also for a duration of about 5 to 10 days.
Sure. And does allergic rhinitis increase the risk of acute sinusitis?
That's a very good question. And there's not a very good one. You know, there's a lot of controversies when it comes now to these predisposing factors. Because if you think of the pathogenesis in itself, allergic rhinitis, there's inflammation, there's mucosal edema, obstruction of the complex, and then mucociliary dysfunction. So if you follow it in that subsequence, one would actually think that it increases it, but fortunately, it doesn't. Allergic rhinitis does not increase the risk of acute bacterial rhinosinusitis or even acute sinusitis. There's no there's no, it's not clinical correlation as per se, but no, it does not.
Okay. And what do you do when sinusitis is an incidental finding reported on a CT scan and it's not symptomatic, the patient is not symptomatic at all?
Yeah, thank you for that question, because patients can experience a sinusitis, an acute sinusitis, and they could still have mucosal thickening 8 weeks, even after complete resolution of the disease. So we do see it quite often where mucosal thickening is reported in the sinuses, and if the patient is asymptomatic, you leave it.
Just leave it there. And what if you find a gastroesophageal reflux disease? What about it? Can it lead to recurring sinusitis?
According to the EPOS guidelines, there has been talks around reflux disease and how it predisposes to sinusitis, but according to the EPOS guideline, which is the European position paper on sinusitis, it does not.
Yeah, I think this next question is about X-ray, but you did mention that X-ray is of minimal use.
It is of minimal use. We've got more
Wants
sensitive
to what
investigations. We've got CT
if
scan.
you find can X-ray of the sinuses tell us anything when the patient has acute sinusitis?
There's more sensitive investigations now. So X-rays are of minimal clinical utility. So ideally, you'd want to do a CT scan without contrast. It's a very good modality. And then only when there's soft tissue complications, then we escalate to an MRI. But generally, sinusitis, we prefer a CT scan. Plain radiographs, because also, even if you bring a plain radiograph, we'd still send a patient for a CT scan.
Yeah. Oh, that's great, yeah. And Dr. Mbuti wants to know, is cavernous sinus thrombosis a common complication? And if so, how do you treat this complication?
It's very uncommon. It does okay, but it's very uncommon. So treatment would be, so at the point where patient has complicated and they've developed a cavernous sinus thrombosis, sepsis guidelines come in, source control. We need to do surgical drainage of the affected sinuses. That's one. Number two, intranasal therapy. Number three, we give broad spectrum IV antibiotics. Okay. And for a more prolonged period. I know when it comes to cavernous sinus, there's always an issue of whether to use anticoagulants or not. We don't use them because they increase the risk of that thrombus embolizing. So to answer the question, to be direct, surgical drainage, IV antibiotics, and then we continue with our topical treatment. And in some cases, if they're still passing the sinuses, we send it for culture, we give culture-directed antibiotics.
Yes. But you did mention that culture sometimes it may not be so, I mean, you may not have to...
No, that was a blood culture.
Okay.
Blood culture don't correlate, they correlate poorly with the mucus culture.
Okay, but you've got
so if you do an endoscopic surgery or even external, once you send that for culture and it cultures a Streptococcus malaria, for example, that is sensitive to augmentin, patient continues with augmentin.
Okay, all right, fine. And Dr. Shah wants to know, in a pregnant woman in the first trimester, how do you manage acute or chronic sinusitis? And any medications which are contraindicated?
Good. So management still use of intranasal corticosteroids because they've got a limited, they've got a local bioavailability, pardon me, please. So whatever you put in the nose, the steroids, Flomist, Genemist, Beclate, it will only be absorbed within the sinonasal mucosa. Systemic absorption is limited. So systemic side effects are they're almost zero. So you use intranasal steroids, Flomist, Beclate, Genemist. Ideally, you'd also want to give a Celex spray or a Celex wash for them to irrigate the sinuses, because obviously that would clear off the mucus, it clear off the environmental irritants, and it improves mucociliary function, right? Because ultimately, once there's improved mucociliary function, ultimately the symptoms improve. So don't give anything systemic. Don't give steroids like prednisone, methylprednisolone.
Yeah, just intranasal. And talk about intranasal treatment. Then, when you give a nasal treatment, give a nasal corticosteroids, Dr. Musehla wants to know what is the best way of giving this? How do you give it? And is there a role for oral corticosteroids? And I'm asking this question because sometimes also I had to get eye drops, and one of the nurses was looking at me and said, doctor, you don't know how to instill eye drops in your eyes.
Yeah, can I just want to demonstrate? Can I just get a spray?
Steroids. Sorry?
Can I just get a spray? I just want to demonstrate how it should be done.
Yeah, that's great. Yeah, I think that would be wonderful. That would be wonderful. Thanks, Dr. Lisba Musehla, for asking that question. Now we'll get a demonstration of how to use this nasal sprays. Just as Dr. Lumata is away, today I was just talking to Kamo that it's they call it a self-care day, a international self-care day. So as healthcare professionals, we need to look after ourselves also. Perhaps we'll share this. Yeah.
All right.
So,
I'm back.
Well, there it is. Yes, International Self-Care Day. Care for myself is not self-indulgence; it is self-preservation. We just talk about how to look after ourselves. I'm sure you, after this presentation, you're going to go home tired and not wanting to do anything, but someone must look after you. So we want to look after you. We care for you too. Okay, go ahead, Doc.
So with the spray in to the side, you can bend, and then you give 2, 1, 2. Sniffing is important because then it distributes the medicine into the sinus mucosa. All right? This on the side, head down, 1, 2. Alternatively, side, up, 1, 2. That's how it should be done.
Okay. Yeah, at least it's recorded. Anyone can go back to the YouTube recording and look at it if we forgot to get confused. Sometimes first demonstration, you forget, you want to go back and look at it again. No, thanks for that demonstration. I think, yeah, on that page from who's in Ireland currently. Clarithromycin, I think you spoke about it, but use it also or not?
Not routinely, unless sensitivity says there's that the bacteria or the pathogen is sensitive to clarithromycin, but generally second line would be a clindamycin or a cephalosporin or a fluoroquinolone.
Yeah,
but yeah,
there was a question by Prof. Makunyane. I seem to have lost it, Prof. If you can hear me, please. I think you were saying about some of the conditions that Dr. Lumata should not forget about complications. If you could just unmute yourself and maybe talk about that. Prof. Makunyane is an ophthalmologist.
Yes, yes.
You work in the same area.
Yes.
Prof. Makunyane, I hope you can, please go ahead. I seem to have lost that question. I saw it coming through, but I can't see it anymore. Go ahead.
By the way, I'm in Rwanda, not in Uganda.
Oh, Rwanda, so not Uganda. So
Rwanda, yes.
Beautiful country.
Yeah, in fact, yes, I had just commented that the list that he mentioned on orbital complications, he should just include proptosis, meaning that the protrusion of the eye as one of the signs of orbital cellulitis. But I would like to thank you so much for a wonderful presentation, Dr. Lumata.
Thanks, Prof. And thanks for always joining us on this webinars. We're encouraged.
Thank you so much.
Okay. Yeah. Dr. van den Bogart, please give me an answer to cause of chronic sinusitis disease. Chronic sinusitis disease. Yeah, I think chronic.
He wants the?
Yeah. She wants an answer. I think there was a question perhaps there. Maybe just repeat chronic sinusitis diseases. It's not clear exactly what she. I know Dr. van den Bogart, maybe if you can just unmute yourself and repeat this question. Mary, if you're able to do so. Don't mind the scratching. There's my puppy is busy. I don't know, maybe he wants attention. Okay, we'll move on to the next question. Yeah. Is the low-grade meningitis a common complication of chronic sinusitis?
Generally, intracranial complications are not common, but yes, it can occur. We've seen it in some cases, especially in the pediatric population. So yes, it can occur. Intracranial complications include meningitis, epidural abscess, subdural abscess, intracranial abscess. So yeah, it can happen. And that's generally by, as I've said, intracranial seeding occurs either by hematogenous spread, septic emboli transmitted through the valvus tabloid veins into the skull base. They connect to the dura. That can cause inflammation of the meninges.
Yeah, there's a question about Clasid. I think it's another 500 milligram BD useful, Clasid.
What's the generic name for Clasid?
I think it's one of the cephalosporins, if I'm not mistaken.
Yeah, so cephalosporins, we generally recommend them for as a second line in addition to augmentin, because augmentin is more of a broad spectrum cover. Remember, some of these patients will have a polymicrobial pathogens. So once you give augmentin, you're covering a broader spectrum, gram-positive and gram-negative. A cephalosporin is more stronger on the gram-negatives. So hence, we'd want to add it as a second line in addition to the augmentin, or unless sensitivity has proven that that bacteria is sensitive to it.
Yeah. And Dr. Kainza wants to know, sagittal sinus thrombosis. Comment is that it's a dangerous condition. How do you prevent it and how do you treat it?
Again, unfortunately, we can't, complications of sinusitis, patient can develop a complication on antibiotics. So we don't have, again, if the patient has got an acute sinonasal disease, again, that intranasal steroid, saline irrigation, monitor the patient closely. If the worsening fever is high, you give your broad spectrum augmentin, monitor closely again for development of complications. And I mean, if you've gotten to that point, then we need surgical drainage, endoscopic or external, depending on the surgeon, the comfortability and the competence. Drain the sinuses, open the ostia so that they can ventilate and drain.
Yeah. In diabetic patients, you commonly see them with these conditions also, and the place of steroids.
So yeah, the place of?
Yeah, oral steroids. Yeah.
We don't, it's so obvious.
Even if it's nasal, even if you use the nasal steroid, even if it's nasal.
No, nasal steroids, definitely they are indicated, because remember we've spoken about that local bioavailability. So there's limited systemic absorption. So in all patients, pregnant, diabetic, intranasal steroids is actually the first line of treatment. Systemic steroids we don't recommend, because especially in diabetic patients, it would increase the risk of adverse or side effects. So we generally do not. Panado, yeah, NSAID, yeah, but systemic steroids, especially in diabetic patients, it further immunosuppresses them. We generally do not recommend use of oral corticosteroids, but there would be benefits definitely in terms of symptoms, headache, facial fullness, the pain, and the discomfort, inflammation. So definitely there would improve some of the symptoms, but risk-benefit ratio at this point would be use intranasal corticosteroid, correct administration, give the right dose 2, and if it's a severe disease, or you can even give 3, because there's that dose-dependent relationship. The higher the dose, the better even the symptom outcome.
Yeah, and Dr. Machachi has just corrected us. Clasid is clarithromycin, the macrolide.
Oh, a macrolide.
Yeah.
Unfortunately, there's actually increased resistance to macrolide, especially azithromycin. So we generally don't prescribe Clasid or macrolides.
Yeah. And this Dr. Mbuti says, I was blowing out clear mucus with fresh blood. On consultation, or maybe one of they said to me, sinuses are swollen. What does this mean? Is this still part of? He was the mumpo was blowing out clear mucus with fresh blood.
Okay.
And on consultation, they said sinuses are swollen. What does this mean? Is it still part of acute sinusitis?
You
When
must
you've got
check the
swollen-
duration of the symptoms, because if that is if this is a first onset and it's less than 4 weeks, yes, it's acute sinusitis. At this point, we don't have enough to say if it's most likely viral or bacterial, but the commonest cause being viral. All right. If, however, it's the duration is between 4 to 12 months, we're in a subacute phase. If this has been persisting for more than 3 months, we're at a stage of chronic sinusitis. So we need to do further evaluation, screen for allergies, and so just on those two that is presented, it's inadequate for me to give a definitive diagnosis.
And if continuous picking of the nose and you bleed,
I mean, if you're picking your nose, you're traumatizing the mucosa, so that increases the risk of epistaxis. We see that commonly in children.
Yeah. Is steaming any value before intracortical steaming? If you know, we saw that quite a lot during COVID, and I'm sure people are continuing to steam their nostrils to prevent,
Yeah, no, those use of home remedies and steaming, Dr. Bila. I wouldn't say there is no pain. I wouldn't say there is a benefit. However, there is no, I don't think it causes harm. Unfortunately, I haven't come across a convincing study that would convince me otherwise to encourage patients to steam. But if they're doing it, it's humid. It also helps maybe with the crusting. Once if so somehow from thick mucus makes it a bit thin, they're able to blow. Sinuses they open up, they're able to deliver intranasal corticosteroids. Then yeah, they can steam. I don't see anything. It's not harmful.
I see there's still lots of questions coming through. One of the slides you mentioned when you treatment regime, you mentioned you wrote the herbal medicine, but you didn't talk much about it.
Yeah, thank you. That picture. Thanks for paying attention. I got from the EPOS guidelines because again, it's some of these articles that are anecdotal, but they don't provide sufficient evidence to start now recommending it.
Okay. Treatment of postnasal dripping and resultant nagging cough. I think we spoke about that.
Yeah, I think I spoke about that. Screen for allergies.
And how
but if there's no allergies, until you use an intranasal corticosteroid.
Yeah, I think this one about the first trimester we've spoken about. Let me just go through very difficult hormones. I think I don't understand this question, but I think they speak about hormones make symptoms worse. I think it's so it's commonly symptomatic with saline rinses and topical steroids.
What about it?
Yeah, I think let me just skip that. I don't understand. Are there any nasal sprays which contain cortisone, antibiotics, and nasal decongestants? They say they use betnazole and drops that are used for eye, nose, and throat to get effect.
Yeah, we do get some sprays in the market where it contains an antihistamine and a steroid. So we do have those sprays. I'm not sure the ones that contain an antibiotic though, because also the benefit, I'm not certain about it. But yes, we do have nasal sprays that would contain an antihistamine and a steroid.
Yeah, I think there's this special. Ulana goes back to cavernous thrombosis, sinus thrombosis. Any place for you working together with the neurosurgeons in that space?
With cavernous sinus thrombosis?
Yeah, because I think they are mentioning this, yeah.
Yeah, no, thanks for the question, but we generally work more with a neurologist rather than a...
What I think we should also mention neurology also. Neurology, neurosurgeons.
We work with a neurologist, definitely, to help manage the cavernous sinus. But from a surgical point, we drain the sinuses. We work with the physicians as well, helping with IV antibiotics, work with microbiology to provide sensitivity. So it's a multidisciplinary teamwork, really.
Mm.
Mm.
You know, when we were going to give a talk, I was thinking a lot about, I think there's a discipline that combines ENT, neurosurgery, and psychiatry.
Mm.
Yeah, I know there's some disciplines that tend to, I don't know if there's any collaboration there.
Not
Yeah,
much with psychiatry, but we work closely with neurosurgeons because sometimes if a patient develops like those sphenoid tumors in the pituitary, we tend to help
yeah,
them with a skull-based approach, approaching the brain through the subnasal mucosa, opening the sphenoid sinus, and then going into the pituitary fossa. So yeah, we do work with neurosurgeons very closely, even in cases of complication when there's intracranial spread. Neurosurgery and ophthalmology and ENT.
yeah, they work together. Yeah, I think there's a discipline that which also combines with the psychiatry. Can the sinusitis lead to otitis media or mastocytitis, given that patients with sinusitis tend to blow their noses quite often?
Yeah, no, it can. It can, especially if you get this period of, remember the sinuses, the mucosa of the sinuses is in contiguous with the mucosa of the nasal passages. So if there's infection in that space, it can easily spread posteriorly into the postnasal space, which is now in close proximity with the eustachian tube. Now, obvious bacteria can migrate from the eustachian tube into the middle ear cleft and lead to an otitis media. So yes, it can. Rarely though, but it can.
Yeah. Mucormycosis,
I think my colleague
Dr.
answered that question, Dr. Ulan. But sorry, Dr. Pila.
Which one?
My colleague
Sorry?
actually answered that question. My colleague answered that question, Dr. Ulan, Dr. Vuyogas Ulan.
Oh, yes. Oh, that's your
Yeah.
colleague. I wonder
Yeah.
why.
Hmm.
Okay, it's good you have colleagues joining you to work with you.
Yes.
Mucormycosis, Dr. Solaisa now wants to know, mucormycosis as a complication. What are the warning signs or symptoms?
Sure, thank you so much. Actually, Dr. Pila, I wanted to comment when you spoke about diabetes patients to say in those patients, it's very important to screen for invasive fungal rhinosinusitis. Mucormycosis must be treated early. Identification would be, so what's most diagnostic? So the presentation in terms of symptoms, it's very non-specific. Patient will complain of a headache, nasal congestion, but when a patient is immunocompromised, diabetic in DKA, when they've got hematological malignancies, any sinonasal symptom they present with, they must refer, because then we need to look into the nose and look for dusky mucosa, because that could be an indication of a necrosis. Because generally with fungal pathogens, they tend to clog the blood vessels, and that affects blood supply into the mucosa, and subsequently patient develops a mucormycosis. So yeah, patients who are immunocompromised presenting with any nasal symptoms, very high, you must refer to ENT for thorough assessment.
Okay. Yeah, I think we got ourselves in a fix there with the classid. Everybody's keep on telling us, no, classid is a macrolide, clarithromycin,
Oh, thank you. No, thanks. I'm glad that you're
I remember
verifying
the good old days as a GP, we used to put now in many years since I stopped using that. Yeah, I'm sure, but you're the younger generation, but you don't use that often.
We love azithromycin.
Yeah.
However, there's high resistance now to azithro. So we
Yeah.
generally don't use macrolides, as I've explained earlier. Yeah.
Yeah. Use of antihistamines combined with intranasal steroids.
For allergic rhinitis, definitely. Because an antihistamine, it's going to help for the allergic component. However, in acute sinusitis, when there's no features of a patient does not have any itchy nose, they're not sneezing a lot, they're not doing this, no features of allergies really, so you don't give antihistamines unless there's an allergic component.
Okay. And the last question, I think, which will be the last one. Can chronic sinusitis cause vertigo and fullness of the ear?
Good question. Good question. Fullness of the ear? Yes, it can. because remember, I've just explained now the relation of the eustachian tube to the sinus mucosa. Any form of inflammation that goes up to the eustachian tube, or if a patient has got polyps, because now when we go into the topic of chronic sinusitis, some develop polyps. If that obstructs the eustachian tube, creates negative pressure build up in the ear, that can cause some oral fullness or blockage. As of it causing vertigo, I really am not sure. I've not encountered it. So I would have to really look into that.
Okay. All right. Thank you a lot, Dr. Lumata. I think we've got to stop here. It's been a good presentation, good discussion points also that we've had. I'm going to ask Dr. Mbuti Lumata to switch on the video and unmute herself. This is my last webinar for today, so I will no longer be part of this webinars from next month. And Dr. Mbuti Lumata, who's the Chief Medical Officer at Clinics Health Group, will be taking over from me. And I just want to say thank you very much for all the last 3 years or so from 2020 that I've been part of these webinars and working with you. But I will miss these webinars. And Dr. Mbuti will take over. And we've got a full month planned for you already. So don't worry. We'll be looking into stroke diseases and with a variety of specialists from different disciplines will be taking part of this. But I just want to say thank you very much and goodbye.
Thank you very much, Dr. Bila. I want to thank you for your service over these past 3 years for these amazing webinars that you have done for everyone. I want to thank all the participants for coming out tonight and once again joining clinics with our webinars. And I want to thank you, Dr. Lumata, for this very informational talk and presentation that you did for us on sinusitis. So thank you, everybody, and good night. And we will see you at our next webinar. Please look out for our notifications. Good evening, everyone.